Well, good evening or good afternoon. My name is Chris Florkowski. I am a chemical pathologist from Canterbury Health Laboratories in Christchurch, New Zealand, and today I'm going to talk about interpretive commenting with a focus on cardiac troponins. Areas to be covered include the definitions of myocardial infarction, why troponins are the preferred biomarker, rule in versus rule out, the importance of clinical context. I'm going to talk about accelerated diagnostic pathways, which is an area where I've had a lot of involvement in work. We'll talk about special cases, including stress cardiomyopathy, and I'll say something about macrotroponins. So here is a troponin result, 169 nanograms per litre. We use Abbott high sensitivity troponin I, and the reference interval up to 99th percentile for females, and we have a one-size-fits-all comment that states a diagnosis of AMI requires a change in troponin with at least one elevated value in the context of suspected cardiac ischemia. Most healthy individuals have detectable high-sensitivity troponin I, and elevated troponin may result from many non-cardiac causes. So for the Abbott assay, the 99th percentile for females, as above, is 16 nanograms per litre, and for males, 34 nanograms per litre. So what is a myocardial infarction or heart attack? It may sound fairly straightforward, but that's not necessarily the case. The definition has evolved over many years. There is more reliance on clinical context and the role of biomarkers, in particular troponins. And we will reference the fourth universal definition of MI published in 2018. You may see the term acute coronary syndrome, which is an umbrella term that embraces a number of definitions, including STEMI or ST segment elevation MI, NSTEMI or non-ST segment elevation MI with troponin rise, unstable angina without troponin rise, but broadly these are terms that are falling out of favour. The original WHO definition was back in the late 1950s and broadly based on an epidemiological approach. We have evolved to a more clinical approach, and one that includes a strong reliance on biomarkers, particularly troponin, and we will reference the fourth universal definition published in 2018. So this is published in the Journal of the American College of Cardiology, or JACC, in 2018, and it differentiates myocardial injury from infarction, defines the spectrum of myocardial infarction, and emphasizes the importance of clinical context and biomarkers, particularly troponins. So we're going to focus initially on differentiating injury from infarction. So the criteria for myocardial injury is detection of elevated cardiac troponin above the 99th percentile upper reference limit, and the injury is considered acute if there is a rise and or fall of cardiac troponin. So this figure sets the spectrum of myocardial injury, ranging from no injury through myocardial injury and its associated clinical context, through to infarction, where there is clinical evidence of acute ischemia. The associated contexts may include anemia, hypoxemia, hypotension and shock, kidney disease, or heart failure, or ventricular tachyarrhythmia. So with elevated cardiac troponin above the 99th percentile, this may be stable, for example, with chronic myocardial injury, structural heart disease, or chronic kidney disease. There may be a rise and or fall, and if without clinical acute ischemia, that is deemed acute myocardial injury, and examples may include heart failure or myocarditis. With ischemia, with a clinical ischemia, that's acute myocardial infarction, and type 1, if there is rupture of an atheromatous plaque and thrombosis within the coronary artery, or an imbalance between oxygen supply and demand. This is type 2, and examples may include severe hypertension or sustained tachyarrhythmia. So next, the fourth universal definition defines the spectrum of myocardial infarction. So as I've indicated, type 1 is the classical myocardial infarction where there is rupture of an atheromatous plaque and thrombus formation. Type 2, where imbalance between oxygen supply and demand. There are other types, including type 3, sudden death, type 4, procedure, percutaneous coronary intervention related, or type 5, related to coronary artery bypass grafting within 48 hours of the procedure. But we're going to focus mainly on type 1 and type 2. So in type 1, there is buildup of atheromatous plaque, which may rupture and predispose to thrombus formation, which may be completely occlusive or partially occlusive, and with resultant ischemia or infarction of the affected territory. So the criteria for type 1 myocardial infarction include detection of a rise and or fall of cardiac troponin with at least one value above the 99th percentile and at least one of the following. Primarily symptoms of acute myocardial ischemia, new ECG changes, and or development of pathological Q waves on ECG, imaging evidence of loss of viable myocardium, identification of thrombus by angiography or autopsy. Type 2 myocardial infarction, similarly, there is a rise and or fall of cardiac troponin with at least one value above the 99th percentile, but on this occasion, evidence of imbalance between oxygen supply and demand, but unrelated to coronary thrombosis, and again with at least one of symptoms of acute myocardial ischemia or new ECG changes. So imbalance between oxygen supply and demand, this could be related to fixed obstruction of the coronary artery, vasospasm, non-atherosclerotic coronary dissection, or other causes including tachyarrhythmias. So biomarkers include troponins, which are predominantly recommended currently, although in the past we have used myoglobin, total creatine kinase, or the cardiac-specific CKMB, and previously AST and LDH. None of these markers, however, are completely specific for cardiac muscle, and even CKMB is now no longer supported by guidelines. So we use troponins, and in particular high sensitivity troponins, which indicates that they can be detected in at least 50% of healthy subjects. So troponin is a protein, it's a component of cardiac muscle, and it regulates the contractile process, the interaction between actin and myosin filaments. There is a troponin C, which is a calcium binding subunit, but has no cardiac specificity, thus there is no assay. There is troponin T, the tropomyosin binding subunit, and troponin I, the actinomycin ATP inhibiting subunit, which is differentiated from the skeletal form by an extra N-terminal 31 amino acids. So the advantages of troponins are specificity to cardiac muscle, sensitivity in that there is a greater increase relative to baseline compared with CKMB due to a 10-fold greater concentration per gram of tissue. As a consequence, there is a longer time course of elevation compared with other markers. Troponins are also predictive of clinical outcomes and predictive of response to treatment. So this is to show that the various markers have different time courses of elevation in the context of an MI, although these markers have been largely superseded by troponins, which typically rise early and may stay elevated for 10 to 14 days. The high sensitivity troponin assays typically rise within 1 to 2 hours of acute myocardial infarction, and this is an important observation because an absence of detected elevation of troponin at an early stage following symptoms gives good negative predictive value, which I will demonstrate later. So cardiac troponins are more sensitive in that they can measure lower concentrations. They are more specific, cardiac specific, but they are not diagnosis specific. There are many causes of troponin elevation, but all essentially have a cardiac origin. This includes cardiac diseases and interventions, heart failure, myocarditis, cardiomyopathy, radiofrequency ablation arrhythmias, and a long list of non-cardiac conditions, including critically ill patients, patients on ICU, those with sepsis, septic shock, renal failure, even ultra-endurance athletes in some settings may show a troponin rise. But the essential point here is that it is important to interpret results in a full clinical context. The next point to make is that clinical scenarios differ. In the emergency department, the essential question is, can this patient be safely discharged? And can we be sure that if that is the case, there won't be an adverse outcome? So ED physicians are interested in a rule-out test, whereas cardiologists are primarily interested in a rule-in test. Is an intervention required? And if so, will this improve clinical outcomes? So in the ED, an estimated 5 to 10% of annual presentations and up to 25% of hospital admissions are related to patients who present with chest pain suspicious of possible acute myocardial infarction. Ultimately, however, the vast majority, maybe up to 85% of these patients, will not have a final MI diagnosis. Previously, patients typically presented with chest pain and underwent a prolonged period of observation and additional testing in hospital, which in reality often necessitated admission. As a corollary, they were spending excessive time in the ED environment, resulting in overcrowding, which we know increases costs and incurs a number of adverse outcomes, including mortality, delayed treatment, pain relief, and not just for those patients presenting with chest pain. So the priority is to achieve earlier discharge, but above all else, safe discharge. So a lot of work has gone into the development of ADP, or accelerated diagnostic pathways, to identify a group of patients at lower risk for whom it is safe to discharge earlier or refer for further outpatient testing. So the approach has been based on clinical outcomes, and in summary has included some observational studies, including ASPECT and ADAPT, which I'll say a little about, to define the accelerated pathways, which have then been tested in randomized controlled trials, applied in practice, and refined further through the application of improved pre-test probability scores, and also including the application of higher sensitivity troponin assays. So the essential components of the accelerated diagnostic pathway are firstly clinical context, pre-test probability score very low, secondly no new ischemic ECG changes, and thirdly negative troponins, that's less than 99th percentile at baseline and 2 hours. So I'm jumping ahead a little bit from the situation I described where less than 10% of patients could be successfully discharged from the ED through a number of studies that have been undertaken over the years to a current situation where 60% or more can be safely discharged. And one of those that I'll mention is the ASPECT study, which was a prospective observational validation study undertaken in a number of Asia-Pacific countries. So ASPECT was designed to assess whether a predefined ADP would identify patients presenting to the ED with chest pain who would be at low risk of harm if they were to be discharged early. So these were patients prospectively admitted to the ED over a 2-year period in 14 EDs in 9 Asia-Pacific countries, at least 18 years of age with 5 minutes of chest pain, and who underwent a multi-marker panel on point-of-care testing at 0 and 2 hours, although managed independently of these multi-marker results by the attending physician. So this is really just to indicate that many countries in the Asia-Pacific region were involved in this study, and I apologize if I've missed any or got the numbers incorrect, and I expect I may be talking to a good number of the investigators tonight. So patient data were collected, the various components of the ADP, and patients followed for up to 30 days for MACE, that is major adverse cardiovascular event, and the data collated and analysed to assign those at low risk. So patients were assigned as not at low risk if their TIMI risk score was greater than 0. This is a pretest probability score. If there were new ischemic ECG changes, or if there were positive biomarkers at 0 or 2 hours on the point-of-care device. So the biomarker panel included troponin I, CKMB, and myoglobin on this Leary device with the cutoffs as indicated, and results were available to the research staff only within 15 minutes. So the components of MACE, that is major adverse cardiovascular events, are as listed, and I won't read them, but they were adjudicated by a panel of cardiologists blinded to the TIMI score and biomarkers. So using this approach of more than 3,500 patients able to undergo the ADP assessment, around 10% were assigned as low risk, and with less than 1% having a major adverse event at 30 days. The accuracy of the ADP for prediction of MACE included sensitivity greater than 99%, negative predictive value also greater than 99%, and negative likelihood ratio less than 0.1. So this is a good rule-out approach. And it is important to note that in the context of this study, in order to achieve that very low rate of MACE events, you need to include all components of the ADP, and not just the biomarkers, the clinical context, and the ECG. So the ASPECT study showed potential for nearly 10% early discharge and safe discharge. The next question is whether the pathway might be further refined or optimized to include only cardiac troponins together with ECG and TIMI score. And the next step was exactly that, using contemporary troponins as the only biomarker. So the ADAPT trial included Christchurch and Brisbane patients from the ASPECT study, plus others. Patients managed according to local protocols, including 0, 6 and 12-hour troponins. The predefined ADP was assessed, and the primary endpoint was 30-day MACE. So on this occasion, Patients not at low risk included those with TIMI scores greater than 0, new ischemic ECG changes, and any positive 0 or 2-hour laboratory troponins, which was Abbott for Christchurch and Beckman for Brisbane, using the contemporary assays of the day. So using this approach of 1,975 eligible patients, around 20% were defined as low risk, and again with very low rates, less than 1% adverse cardiovascular events out to 30 days. And with corresponding sensitivity greater than 99%, likewise negative predictive value and negative likelihood ratio less than 0.1. So this pathway is a good rule out. And again, in order to achieve the very low rates of MACE events, you need to include all components of the pathway, not just the biomarker, which is troponin in this case, but also the pretest probability score and ECG findings. So these trials now have the potential to assign up to 20% of patients as low risk and safe for early discharge, with implications for ED overcrowding and costs. But these are observational studies, and they were subsequently supported by randomized controlled trials. And this was the randomized controlled trial that was undertaken in Christchurch and subsequently published in JAMA Internal Medicine in 2014, which confirmed that approximately 1 in 5 patients with chest pain could be safely discharged to outpatient follow-up in less than 6 hours, and that this strategy could be replicated in other centres with no extra resources. And this is something that has been more widely adopted throughout New Zealand and the world, and in fact with further refinements as I'll describe. With respect to pretest probability, the TIMI score was an instrument that was developed primarily for the coronary care environment and not the ED. So the next step was to develop EDAX, the Emergency Department Assessment of Chest Pain score, adapted to the ED environment, and for which we were able to show that 30 to 40% of patients presenting with chest pain could now be assigned as low risk of major adverse events. So there are many components to EDAX, including age, gender, risk factors, other symptoms. So less than 16 is deemed low risk according to EDAX, and greater than or equal to 16 not low risk. So you will recall I said earlier that in the setting of acute MI, high sensitivity troponins typically rise within 1 to 2 hours. So this is an important observation in the sense that somebody presenting with acute symptoms, if we are not seeing troponin elevation in this early time frame, then this is potentially a very good rule out test, which has been supported by a number of studies. And there are many studies of this type, but this is one example, a cohort study, a prospective study of over 6,000 patients with suspected acute coronary syndrome, in whom high sensitivity troponin I using the Abbott assay was measured at presentation. And the outcome of interest was MI or subsequent MI or cardiac death out to 30 days. The final conclusion was that in patients presenting without MI, a high sensitivity troponin I was less than 5 nanograms per litre in 61%, for which there was a negative predictive value of greater than 99% for the primary outcome. So with high sensitivity troponin I at very low concentration, less than 5 nanograms per litre at presentation, there is a very high negative predictive value. So this is our pathway as it evolved over several years, incorporating EDAX and ECG. So if patients present with suspected acute coronary syndrome and there are no red flags, for EDAX greater than 21 or new ischemia on ECG, they undergo cardiology assessment and admission. For EDAX less than 20 and no new ischemia, they undergo ED assessment, and if the initial troponin is less than 5 and it's more than 2 hours from the time of symptoms, then they are discharged with a view to being further evaluated the next day. For troponins between 5 and the upper reference limit, then the further management depends upon the level of EDAX score and the results of further troponin testing. So this is the status of our pathway over several years of evolution. So as I said earlier, we've moved from a situation over 15 years ago where less than 10% of patients presenting to the ED with chest pain could be discharged early. And we've evolved through many studies. I've mentioned ASPECT, the key observational study in the Asia-Pacific region, the ADAPT study, which was undertaken between Christchurch and Brisbane, leading to nearly 20% of patients being able to be discharged early and safely from ED, and subsequently with the incorporation of EDAX, over 30% could be discharged early, and with the adoption of high sensitivity troponin assays less than the lower limit of quantitation at presentation, up to 60% of patients can now be discharged early from the ED using these accelerated pathways. So I think it is a great success story of collaboration between ED physicians, cardiologists, and the clinical laboratory. And we have been able to take it a step further. With the advent of COVID, there was an imperative to try and further minimize the time spent in the ED environment, an imperative to try and diminish any unnecessary duplication of assessment between ED and cardiology, clearly with the presence of significant infection risk. So the COVID pathway was developed using all the data that we have gathered, including clinical outcomes, and now with more reliance on early troponins being less than the limit of quantitation or in a low intermediate range, coupled with the timing of symptoms, we are able to identify patients who can be safely discharged the next day without further troponin assessment, or those who can be discharged with a view to undergoing further troponin testing and streamlining the numbers for whom cardiology review is appropriate. So this is the COVID-19 ADP pathway. And with adoption of this, even compared with our previous ADP, we were able to show a significant increase in patients having only one troponin, a 30-minute reduction in the mean length of stay for people discharged home from the ED, and a nearly 25% reduction in hospital admissions of patients ultimately assigned as having non-cardiac chest pain. So I mentioned that clinical scenarios differ, and we've talked a lot about the ED environment and the importance of a rule-out test, and I've talked through the evolution of accelerated diagnostic pathways, and I think you'll agree there is a lot of work that has been done. There are a lot of supportive data. On the rule-in side, however, it is much more contentious, and there is less robust guidance available from the literature. So let's come back to the criteria for type 1 MI. Detection of a rise and or fall of cardiac troponin values with at least one above the 99th percentile. So exactly what is a rise and or fall? And it's not clear. So how do we define a significant change? And I can make a few discussion points. Firstly, it should exceed the analytical variation, 2.77 standard deviation, so corresponding to approximately 20%. Many publications suggest that a 30% delta is more specific. There are publications that suggest that absolute changes are more discriminatory than percentage changes, although I guess this partly depends on the baseline. And there's been a number of studies addressing biological variation and defining reference change values. These are based on variation in primarily healthy individuals and with reference change values varying from 30 to 90% or more. It is also worth pointing out that a lot of the research has focused on trying to define the optimal delta for a particular assay, and which is often referenced to MI, which has been assigned incorporating another troponin. So this is a contentious area. And this is an algorithm for application of high sensitivity troponin T, which I know is in widespread usage in many centres in New Zealand. So the interpretation depends on your baseline troponin, retesting after 3 hours. And if your baseline is less than 50 and there is a greater than 50% change, that is significant. And if you are greater than 50 nanograms per litre, then a greater than 20% change is significant. However, if you have an adverse prognosis, then further testing may be indicated at a later time point. Often, however, there is no doubt. There are typical ECG changes and a clear and very marked troponin rise. So this is an interesting case of a 77-year-old woman presenting with ischemic chest pain back in 2011. And this is troponin I in micrograms per litre. So it corresponds to 1400 nanograms per litre or 870. So clearly a very marked rise. But note the date, 23rd of February 2011, which was a very significant date in the history of Christchurch. And there were significant and very widespread ischemic ECG changes. Coronary angiography, however, was essentially normal. And it was questioned whether she may have what's called Takotsubo's cardiomyopathy or stress cardiomyopathy. And the significance of the date that I mentioned earlier is that it was immediately following this very significant event in the history of Christchurch, namely a 6.3 magnitude earthquake that struck on February the 22nd, which was a very stressful event for anybody who was living there at the time. In fact, nearly half the cases admitted in the first 48 hours after the February earthquake were considered to have this stress cardiomyopathy condition. So this was present in 21 of 44 patients admitted in the first 48 hours, so nearly half the cases. And this was the headline in the local press: Broken Hearts, Swamp City Hospital. So a condition which is normally seen maybe once or twice a month. Following the earthquake, there were about 10 people a day presenting with this condition. I'll say something about troponins in renal failure. They are elevated, and troponin T possibly more than troponin I. It indicates myocardial injury, but not necessarily infarction, and it is predictive of adverse clinical outcomes. Other issues include interfering antibodies, macrotroponins, which are high molecular weight complexes and which may affect up to 5% or more of elevated troponins, and I'll say more about this. False positives may also be seen in association with rheumatoid factor. The key message, however, is to suspect when persistent elevation doesn't fit with the clinical scenario. So this is the case of a 46-year-old man presenting with chest pain. His high sensitivity troponin I was 171 nanograms per litre. Cardiovascular exam was normal, as was echocardiogram and angiogram. Troponin T was elevated, though only just, and Siemens troponin I was also elevated. PEG, or polyethylene glycol precipitation, using the Abbott assay showed 2% recovery compared with 37% in matched controls, and it was suspected that he may have a macrotroponin. So this is gel filtration chromatography, and this is the patient's troponin I running in a higher molecular weight position compared with native cardiac troponin I, and the elution fraction on electrophoresis shows the troponin peak running close to fibrinogen, so supportive evidence of a macrotroponin. And this case was published in Clinical Chemistry and Laboratory Medicine in 2016. A lot of attention had already been drawn to this topic from this publication by Warner and Marshall, and they demonstrated a high molecular weight complex containing immunoreactive troponin I and immunoglobulin, in other words macrotroponin, in 5% of patients with elevated high sensitivity troponin I on the Abbott assay. And a lot of work has been done on this topic by the Auckland group, who have done studies of immunoglobulin depletion by incubation with protein A and demonstrated that macrotroponin may be present in more than 50% of samples, and they conclude that the observed discrepancy between troponin assays may be partly attributed to the presence of macrotroponin I. I think the key messages are, firstly, when to suspect macrotroponin, when results are discordant from the clinical picture, and this is often a chronic stable elevation without obvious explanation and often following extensive investigation. This is something that is generally very difficult to detect and deal with in the acute phase. Having suspected it, however, the approaches include, firstly, alternative assays, and bearing in mind that these may also be affected by the presence of macrotroponin. Secondly, polyethylene glycol precipitation is generally available and expedient. Protein A treatment is another approach. And finally, the gold standard gel filtration chromatography, which is definitive but generally very cumbersome and not something that would be recommended for routine use. So this is a possible comment when macrotroponin has been suspected or demonstrated, and this is from the Auckland group and as proposed by Dr. Leo Lam. Macrotroponin I may affect all troponin, including troponin T tests, leading to discrepancy in results between methods and laboratories. Presence of macrotroponin I is associated with prolonged troponin I elevation. The findings do not exclude cardiac injury. Serial troponins from the same laboratory should be performed where acute cardiac injury is considered. So this brings me back to our one-size-fits-all comment for troponins, and I think you'll agree from what I've talked about, the scenarios for using troponin tests differ, certainly between the ED and cardiology environments, and it is difficult to craft a comment that is specific to any one situation without being fully aware of all the factors involved in the case. So that is why we have stuck to using this single comment to cover all the bases and mindful of the 99th percentiles which apply to the high sensitivity Abbott troponin I assay that we employ. So this takes me back to one of the original slides, and these are the areas that we've covered in some detail: the definitions of myocardial infarction, why troponins are the preferred biomarker, rule in versus rule out, and with a lot of emphasis on rule out, accelerated diagnostic pathways and how these have evolved and are being constantly refined. And we've talked about some special cases, including stress cardiomyopathy. And finally, I've said something about the identification of macrotroponins. So thank you for your attention.